All right, good afternoon. Happy Tuesday. Last week in October, we were just talking about potential snow coming this week. So certainly we're right in the midst of fall here. I hope you're all having a great week thus far. We're very excited about today's topic and our guest. So Dr. Cynthia Whitaker is here with us today. So for this chamber exclusive, as with all of these, we encourage you to ask questions. So feel free to use the Q&A feature at the bottom of the screen. If you send those over to me, once we open things up, I'll field those questions. You can also, if you need to send an email, feel free to do that too if Zoom isn't your thing. But from here, I'm going to turn it over to Dr. Whitaker to give us a little bit of the lay of the land, tell us who she is and what things look like in her world. So thank you again for being here today.
Well, thank you for having me, Kate. I appreciate it so much. And of course, as the world of Zoom would have it, they're currently doing some little construction right outside my wall outside. So do ping me if it distracts the audio or anything in any way, please.
Okay, I can't hear anything now, so you should be good.
Excellent, thank you. So I appreciate the opportunity to come on, and Kate did ask that I start with a little bit of my background and where I'm from and how I ended up here at Greater Nashua Mental Health. So my background is as a New Englander. I grew up in Rhode Island, and I am a New Englander at heart. I love 4 seasons, I love snow, and I love summer and a beautiful fall and spring in between. And while I was growing up in Rhode Island, I had a relative who was in the psychology field. And so when it was time for me to get my undergrad, I was kind of intrigued by psychology, as that's what he did. And I also kind of had this other interest in sign language and speech and hearing sciences. And so I did a bachelor's degree in both psychology and speech and hearing sciences. And I got to this decision point in my career about, was I going to go to graduate school to be a speech language pathologist, or was I going to go on and do some graduate training in psychology or social work? And so at the time, as a bachelor's level person, I was working in a psychiatric hospital as a mental health worker. And I was fluent in American Sign Language to some extent, and was about to actually leave to go on vacation up here in New Hampshire while I was working down there in Rhode Island. And a deaf person came into the hospital to be admitted for having some suicidal thoughts. And this was pre-ADA, and there wasn't anybody that could communicate with her. And so I ended up as a not trained interpreter, not trained more than having a bachelor's degree in psychology, supporting this patient getting admitted to the hospital. I tried to interpret for the psychiatrist doing the admission, but I couldn't because I wasn't trained as an interpreter, but I could communicate with her. So ultimately he handed me the questions and had me do the eval and admit her. I hung around for a little bit, got her situated, tried to provide some resources about how the hospital could connect with interpreters, but then ultimately took off for the weekend, snowmobiling up here in New Hampshire. And when we got back on Tuesday and I went back to work, she greeted me with the biggest smile, hug, I'm so glad you're back, but then went on to tell me about having been tied to a bed and not sure exactly what happened, having been injected with poison because she didn't realize it was a medication, and not having been able to talk to anybody the entire weekend she was there. And boom, at that moment, I decided it was psychology, not speech and language, that I wanted to continue on in. And so we moved to New Hampshire, and I enrolled in a doctoral program in psychology and simultaneously in a sign language interpreting program at UNH Manchester. And so I graduated from both programs, came here to Greater Nashua almost 15 years ago, and started what I called my dream job. And I coordinated deaf services for deaf mental health for the state of New Hampshire here out of Greater Nashua for multiple years before I continued to move up in the organization and take on bigger and bigger roles. And what's interesting is I don't know why, Kate, but when you sent the email saying, how did I end up where I am now? In that moment, I decided that I wasn't going to end the story here. This is usually where I end the story. This is how I got to be where I am, this really impactful story. But when I think about my kind of highest hopes for what I want people to walk away with today, it's knowing that mental illness can impact anyone. It's knowing that there's always hope when your mind tells you there isn't. And, you know, to really think about what can we do to impact the stigma. So when I think about that, it sort of tells me it's important for me to tell the rest of the story. And so the rest of the story is that after moving to New Hampshire, almost graduating, in my last semester of my doctoral program, on a snowy day, almost 20 years ago, I had a really bad car accident where a young driver on his college break home, spring break in March home, lost control of his father's SUV. He thought his car could go a lot faster in the snow than it could because it was an SUV. Well, I ended up in a wheelchair for months, unable to walk. I had to have people come, help me cook, help me clean. I even had to have a commode in my living room because at the time we lived on a 2-floor apartment and the bathroom, kitchen, and dining room were downstairs and the bedroom and living room were upstairs. And I could not maneuver between the 2 floors. So I always have been a very positive person, a person of much faith. And I accepted that help. I had people come and helping, but man, I found myself having anxiety, flashbacks, unable to work on my dissertation, which needed me to work on it. And honestly, at times even suicidal. And when I think back on it, that was really a pivotal time for me, and it's how I really kind of ended up where I am today, which is, you know, now as the interim president and CEO here at Greater Nashua Mental Health. And I got to that place of despair because of stigma. So I was suffering with those symptoms of PTSD in silence because I felt, oh, here I am in school to be a healer. I can't need healing. I can't let people know I'm having this reaction to just a car accident. You know, luckily, I eventually found treatment in what's called EMDR that really helped heal the trauma in my brain. But it really makes me super sensitive to stigma. And what I think is really important for us to be thinking about right now is what our first responders go through. So they too are seen as the rescuers who save. And so it's hard to admit when maybe they need to be rescued or saved themselves or helped. Or, you know, a father or a businessman who, in whatever, our minds tell us we should have this, we should know better. As a person of faith, right? I believe in whatever somebody's belief is. If you have a strong faith, sometimes you might tell yourself, well, I should feel this way inside because I have this other faith. And those are just not true, and it perpetuates the stigma. So yes, I got here because of that incident that happened back before I started graduate school, but I truly wouldn't be here in the role that I'm in, functioning the way that I have, if I hadn't finally broken through of that stigma of being a healer who also needed some healing. So if it wasn't for that, I wouldn't be here getting to celebrate the 100-year anniversary, by the way, of Greater Nashua Mental Health right now. So that's the true story of how I got here. But I will gladly shift to what the organization does. But I see you unmuted, Kate, so I'll let you chime in.
Just to say thank you for sharing that with us. It's really interesting. I mean, you're just a person, right? Like, I think we forget sometimes when we take on those roles of, you know, parent or, you know, business leader, whatever it might be, that we're still just people. So thank you.
Exactly. And that mental illness and symptoms impact people. And so if we're all people, we can all be impacted. And so, that certainly jumps right to kind of the most important things that we can do to help one another is to make sure that we're not using words that stigmatize, right? So to not call somebody that is suffering with PTSD crazy, right? Like, I mean, here I am, doctor this, all of that, all those accolades, but I'm still a person. And so those kinds of things are important. I think allowing ourselves and allowing other people kind of just grace to be who we are, to tell stories, to share stories. One of the things when I also think about how people can help, I often think about like a triangle of help. And that the tip of the triangle are people that need the professional help, are people that need even like significant help, like inpatient. And then as the triangle goes down, there's more and more people that need different levels of help. And so the most people actually need a lower level of help or support. So they need colleagues, they need family, they need faith communities. They just need somebody to listen and not speak ill will of them, to come walk alongside or speak positively with them. So, in thinking about what's the best way we can help people is remembering that not everybody needs that top. And so, what can you do down here at the community level to create communities that are supportive, open, caring, allow people to have bad days when they have bad days, speaking about your own bad day when you have a bad day, so it's welcome for other people. So that I think kind of stems from that piece as well. All right, so what does Greater Nashua Mental Health Center do? So we're 100 years old this year. It's been a little weird to celebrate during this COVID time. All the things you would think you would get to do to celebrate such a milestone, we're not getting to do, but we chose the month of October to really celebrate internally. So we've done a lot of fun things. But Greater Nashua got here from 100 years ago by responding to what the community needed at the time. So we started like with chaperoning dance halls, monitoring streetcars for sanitation, meaning you can't spit, and making sure people weren't swearing on them. We got involved in teaching citizenship and English to folks that were immigrating to the United States at that time. And then very quickly, the center got involved in mental health. In the mid-20s, even with what they called a mental health hygiene clinic at the time, or fresh air camps also to have kids from the city come up to rural New Hampshire, rural Nashua. And then, so, we already had that 40 years of history when in 1963, President John F. Kennedy in the Community Mental Health Act called for community mental health centers to take people out of hospitals and bring them into the communities. And so with that 40 years kind of already under our belt, it made sense. And so we've been a community mental health center ever since there was such a thing as a community mental health center in the 60s. And so what that means now, kind of flash forward to today, that we are one of the 10 community mental health centers in New Hampshire. Each one has its own region, but a lot of those regions are for our community-based services. So if we're providing in-home services, or if we're supporting somebody in daily tasks for them to be independent, like going to the grocery store or going to the bank, we need to be in their community for those services. We have other services like our substance use disorder services that don't follow that same catchment area. But that's why those catchment areas are there, because the community mental health centers were meant to work with people in their communities. So it clearly wouldn't make sense for us based here in Nashua to, go help somebody up in Berlin, because we're not in their community. We can't help them there. And as a community mental health center, all 10 centers across the state help folks from zero all the way up the entire lifespan. So we have specific programs for children, youth, and families, including some outpatient substance use programs now for adolescents, to folks for programs for folks with some severe mental illness, where we provide supported employment to help them get jobs. We have a health mentor program to help folks with severe mental illness learn better health habits, because we know that folks with severe mental illness die 25 years younger than the rest of the population. So we knew that it was really important to do that. So we've got so many services here. And the one that I'm very dear to my heart, of course, are deaf and hard of hearing services, which is how I came to be part of this agency, which also serves the entire state of New Hampshire here. So we've got all kinds of mental health services. And so I think sometimes when people think about services, they think the traditional kind of therapy and medication. And we do that, and we do a whole lot more. And that's kind of what sets us apart, and why it's important for us to treat the folks that need that wraparound support. And so we have an open access program here, which essentially means people can walk in, get an eval any day, Monday through Thursday in the morning. And part of that process is to figure out if we are the right spot for people, and if we're not, to help them find who is. Because often if people really only need or could best be served by therapy or medication only, we're not the place for folks, because our specialty is really this wraparound service with, community-based supports and functional supports for daily living skills and supported employment, and having substance use and mental health services under the same roof. So that's kind of what we're known for now. Then your last question of me, I feel like I'm interviewing myself. Your last question of me was about the impact of us to us on COVID. So it's been tremendous, the impact. And when the pandemic hit back in March, we had to very quickly shift our services to being more telehealth. And again, when I say that, not a big deal if in your thinking, you're thinking about therapy and medication, right? That's the same that many of us are experiencing with our own primary care doctors, right? Telehealth visit, therapy, medication, not a big deal. But how do you support somebody with taking their medication when you usually go to their house twice a day to make sure they're taking their meds properly via telehealth? How do you help folks with the mail, with the grocery shopping, with on-the-job training, with showing people how to properly exercise, all these other kind of community-based things that we were doing in person that we had to shift to telehealth? And that gets lost on a lot of people when we talk about it. So even those services we are providing, but wow, did it take a lot of creativity. So we had, we would drop off the medication as an example for somebody, and then have a phone call with them or a video with them. Okay, now open it. Now, all right, tell me what it is. Okay, and so really changing things there. We had setting up appointments with folks at a certain time that they would open their mail. So instead of being there with them while they open their mail, we would set appointments with people that they would open their mail while we were either on the phone or on the video. So it really, really took a lot of creativity on our part to be able to figure out how to continue to provide our clients with the services that they need when we talk about the whole continuum. So we did shift to doing about no telehealth, to about 70% of our services being done remotely within a 2-week span back in March. And now we're down to about 50% of our services are provided either via phone or via video at this point. So it definitely was a lot onto our organization. And so that's kind of how it impacted us organizationally, but then there's kind of how it's impacting the community. And so a lot of increase in symptoms. And so when I say that, I think a lot of people can imagine folks that didn't have mental health disorders are feeling anxiety or stress for the first time. But folks that had mental health disorders are also experiencing a relapse in symptoms or exaggerated symptoms. So it's impacting everybody across that whole span. And so we've really had to be much more responsive to folks coming in. Luckily, the state thought ahead and early on in the pandemic, asked the federal government for support, and they put a new, an extra emergency services clinician at every one of the centers, specifically to address like services that are needed due to COVID. And so, for example, we've worked with some folks that were working in nursing homes that witnessed a lot of loss. And so now they're having their own kind of grief reaction. And so they don't necessarily need our full array of services that we would typically offer, but having this rapid response is what it's called, that the grant that the state received, allows us to serve that person quickly and provide them with some short-term services that kind of gets them over the hump and can help them then decide, do they need something long-term and ongoing somewhere else, or did they just need that support through that crisis? Because what we don't want is people that are experiencing distress like that example to have to wait 3 months to get on a therapist's calendar somewhere else. So we are seeing a little bit more of people who we might not traditionally see because of the impact of COVID. And then sort of the last thing I'd like to say before we open it up to some more questions, because that's really where I do best. This is really hard for me, just kind of talking at a screen.
You're doing great. This is fascinating.
Is where are we headed? So folks may have heard that the state has made some changes with their mobile crisis contracts and what's happening there. So there's a couple of different things happening, but it all boils down to that Greater Nashua Mental Health will be taking over the mobile crisis services here in the Nashua region. So we are in the middle of a transition plan that has us being truly live next month, next week, I guess, on Sunday, November 1st. But like the other centers before us that started this, we won't have the ability to have apartments and things like that right off the bat, right in the beginning. We certainly need to, stand those up, create them, have a lease for that. But so we are expanding our services by leaps and bounds right now, mobile crisis being one example. Another example being our children's adolescents and family department. And we knew it was kind of an underserved group that we could be serving more than we were. And so that program for us is just expanding tremendously. So we're working more with schools. We already were, but we're doing it even more now. We've expanded the services to that 0 to 5 age range. In the past, somebody might have applied for services here and we would have said things like, we don't treat kids under 3 or we don't treat kids under 4. But now we've gotten some specialized training and working with children and families with kids that are 0 to 5. We're getting some specialized training in how to make diagnoses with kids that young. So we're really excited about those expansions. And I would say the other thing of kind of the where are we headed in the future is more of what's really been built by the IDN, or the Integrated Delivery Network here in Nashua, which you've probably heard about in different places. It is coming to an end, the 5 years of that, but it's really opened the doors for a lot of collaboration. And so, really kind of seeing where do we fit in the community? How do we make sure we're collaborating with our partners to fill the needs of the community without kind of duplicating efforts, or making sure there's a whole continuum of care of services? And so those are kind of some of the things we're embarking on and paying attention to in these next 100 years. I'd say it's really just more of what we've been doing, which is paying attention to what the community needs and trying to be responsive to those, and flexible.
Excellent. All right, so let me turn off the spotlight piece and remind everyone that if you have questions, feel free to use the Q&A. A couple of you submitted them when you registered, which is awesome. But before that, so I want to say I went to UNH Manchester as an undergrad, so kind of nice we have that in common. It's a wonderful school.
Mm-hmm.
So I'm curious, so how many staff do you have? Do you have volunteers?
So we have budgeted staff and regular real staff, right? Those are two different numbers right now with the behavioral health workforce issues we have going on. But we have about 220 or so staff right now. We serve about 5,000 clients or so every year. So we're not small by any means. I appreciate the question about volunteers. It's been something that we've struggled to figure out here. And I think some of it's related to stigma. And so I want to make sure we approach it mindfully, right? We've often said we can't have volunteers because of confidentiality. And if you run into a client that's, we break in their confidentiality. And so we traditionally have not utilized volunteers. But I do wonder about, are we our own worst enemy there? Often what we do though is we partner with others and volunteer for them, or if they use volunteers that are in things that support our clients. So a great example of that is the United Way baby shower that was happening in this month of October, right? So a lot of our clients could take advantage of that. So people volunteering at things like that our clients then can be part of is just as helpful to us as if they were here volunteering for us. So that's my way of saying we don't really have them, but I wish we could, but still volunteer in other places.
Yeah, it's complicated. So
it is complicated.
You mentioned you have counterparts in other parts of the state. And so what does Greater Nashua look like versus some of those other places? Like, what is different here? What is is the structure different, or the services different? Like, what is it that makes kind of you different than those other regions?
It's a great question. So actually all 10 centers together have an association called the Community Behavioral Health Association. And so all 10 centers make up that association. And the idea of that association is actually to bring better alignment between all 10 centers, to make sure that the system is sustainable across the state. Because one of the last things we would want is for the services you have access to be dependent upon your zip code, right? So we want everybody to have access to the same services. That said, however, there are some things that make us different. So one was we weren't doing a lot of emergency services. We had a telephone that we were staffing 24/7 and people could call us. But that was one thing we weren't doing that we are now about to do, which we're very grateful for. And then certainly the deaf services program makes us different. And we actually partner with the 9 other centers to help support anybody that's deaf or hard of hearing in their regions, because we have staff that are fluent in American Sign Language. We actually, as an organization, have on staff more deaf professionals than any other organization in the state of New Hampshire. So that sets us apart. Our dedication to substance use disorders sets us apart. Some of the mental health centers have similar programs that, we have an IOP, we have a specific program for folks with severe mental illness and severe substance use disorder. We're the treatment providers for the Nashua Drug Court. That's not the same across all 10 centers. Some centers don't have very much in the way of substance use disorder. And the final one that stands out for me is our first episode psychosis program. And so this is a program that's specific for young folks that are experiencing psychosis for the first time in their lives. And there's an evidence-based practice, which is our fancy way of saying there's a lot of research that shows this intervention works well. That what folks really need at that time is a lot of hope and family intervention so that the family doesn't increase the stigma or inadvertently do things that could cause the trajectory to go in the other direction. And so we've been kind of the model of that for the state. Right now, there's a lot of action happening at the state level to figure out how to bring that to the other regions. Because again, we don't want folks to get that great service only when they live here. We want folks in Concord to be able to access it too. So we're trying to support those efforts to bring that to other centers. But that is something that we have right now that that others don't.
Well, and I would imagine certainly Greater Nashua, not just the city itself, but as the city being the most diverse in the state, I would imagine language, do you have translators or interpreters?
Thank you for saying that. That is another thing that actually sets us apart. So we have on staff a full-time Spanish speaking interpreter and a full-time American Sign Language interpreter. We are also the only community mental health center that has a language access coordinator. If any of your members are familiar with hospitals, a lot of hospitals have a person or a department whose role it is to ensure that patients or clients have access in their language. So we created that role here. And so part of that then propelled us to setting up lines, phone lines. So a client or a prospective client can now call a number that connects them to an interpreter that then connects them to our phone system. Whereas before, they might call us, leave a message, it might be awkward, it just didn't work as well. And so we now have 4 telephone numbers, our main number, and then the main number that has direct interpreting access in just about any language. And then an emergency number or 800 number and an alternative emergency number that's available in another language. So thank you for saying that, because that is something that's very different, and for New Hampshire, something that we take really seriously.
Well, right, I would imagine that first impression, right? You know, I'm just guessing, but that it's sometimes hard enough for people to seek out help. And if they seek out help and it's hard, right, to sort of get through, exactly, that I'm sure makes it more difficult on the other end. So yeah, it sounds like that new program is great.
Yeah, it's a good point.
So what sort of partnerships do you have? Our Leadership Greater Nashua class, our spring class had a couple days postponed and our fall class has started. And so in one of their sessions, we had the Nashua Community Music School talking about art therapy. And so as you were talking, I was wondering, do you have partnerships with other organizations in the area to bring in some of those specialties?
You know that we haven't recently, we have in the past, but we haven't recently. And I think that's kind of part of where I'm seeing our trajectory going, that those are the kinds of things we want to make sure that we're fostering. So a lot of our current partnerships are things like public health. So we've sponsored immunization clinics on our property for our clients, with the partnership with public health. We have a physician from Lamprey in an exam room in our building providing primary care to our clients a couple of days a week. We've developed some really great relationship with Southern New Hampshire and their access team, which is their behavioral health team within their emergency room. And so we have a daily call between our 2 emergency teams to make sure that if somebody's been in the ER that doesn't have behavioral health services, our emergency services staff follow up with them and offer our services. or if they were our client, that we make sure we follow up with them. Just to name a few. I mean, I've already mentioned United Way. They've been such a great partner for us in many, many ways. Yeah, just there's so many. I mean, Nashua is a great community. Substance use disorder providers are another place where we're really trying to make sure we have collaborative partnerships and creating kind of that continuum of care for people.
Well, and I don't know that if you can function in New Hampshire without partnering and collaborating, right? I feel like it's just the fabric of who we are, right? Whatever the role.
Exactly. Well, and in some ways, I think it's part of that, Yankee ingenuity, if you will. Like, why would I try to solve a problem myself if somebody else has already solved it, right? Like, it's better for me to walk alongside that person and say, okay, how can we solve this better together? To not duplicate efforts or to not, spin our wheels trying to solve something that somebody else is already doing. So those kinds of things. And another thing that pops into my head is like the HIV task force, right? Like, their specialty is working with individuals that have that diagnosis and are walking that journey in their lives, but they sometimes need the support of psychiatric services. And so how do we work together? Or, Harbor Care in providing residential treatment for substance use disorder or residential treatment for mental health problems, right? But then when people leave those settings, they might need outpatient, or, as people are transitioning, how to make those things smoother. So, I mean, it's just vitally important that we collaborate and have good relationships with one another in our communities.
For sure. So I know you mentioned telehealth and creativity and service delivery, but one of the questions that came in ahead of time was sort of, what is the most significant change you've seen in your field since the pandemic? Is there anything else that you want to add to that? Certainly it's shaken up the world.
It certainly is shaking up the world. I mean, if nothing else, I think it's really highlighted how vitally important mental health is and how vitally important socializing is. I mean, this isolation and having to shelter at home and the stress that's causing on families, whether it's, spouse or some other intimate relationship, or this parent-child and other kind of family relationships. I mean, the amount of stress that it's causing on people, I mean, certainly underscores how much we really rely on our village. And when we don't have access to our village, how hard it can be. And so, how do we, both as a system in mental health, but also kind of as community, make sure that just because we're not able to be in somebody's presence, we're not out of their life. And I think it just keeps underscoring that everywhere I turn. I think we see just how important services and just being there for other people really is. And, of course, that looks different when I'm talking about my neighbor versus if I'm talking about somebody with a severe mental illness diagnosis. But kind of that we are here for you. We will stay connected, whatever it takes, despite what's going on. And I think that's kind of how telehealth is, right? Like we're getting creative in how we are connecting to people. And that's a lesson we can all learn, like get creative.
Well, and maybe a month or so ago, we had Bill Brewster from Harvard Pilgrim join us for a Chamber exclusive, and he talked about how, at least for them, I don't know for other providers, but they eliminated copays for mental health, telehealth coverage since this all hit. And so I'm sure, access, that's made a big difference for a lot of people. Again, I'm not sure about other providers, but that's a change.
Well, and it's a change I hope we can keep in some ways, right? So we've essentially said, we'll come to you, we'll meet you where you're at, we'll provide access. And for some people, even amidst COVID, that means coming and being seen face to face in the safest way possible. But it's also provided access to people that we might not have been able to see, people on the outskirts of our community that, struggle with transportation to get to us. they're not needing to figure that out. So they're more likely to keep some appointments with us when we can do them via telehealth, or the fact that I can have a phone call right now with an older adult who is very nervous to come out, but who also can't access the technology without increasing their stress. We don't want to increase folks' stress. So it really has improved our ability to reach people where they're at, rather than expecting everybody to kind of meet us on our term. So I do hope that at least some of this continues after what we've learned from this.
Well, it's so interesting in so many ways. I feel like this has been like, you know how they joke about the strategies for getting in a pool, right? You have the people who like put their toe in and take the steps or the ladder and sort of adjust at each point. And then you have the people that, cannonball, they're in. And it's like working from home, right? So many companies, no, never, can't do it. It's just not something. And then all of a sudden, everybody had to be home. And so,
right,
like, even though we sort of jumped, 10 miles ahead, I think it's caused people to think about like, well, that was actually okay. Is there a way that we can do this long term in a balance, right, that works on both sides? Because I would imagine cost wise, maybe it can't be free for everyone forever, but maybe there's a way to offset, like I'm sure at least having those conversations is beneficial.
Yeah, exactly.
So we have another question. So homelessness seems to be an increasing issue in Nashua. Help us better understand why this is happening and what part your organization plays in addressing this issue.
That is another great question. That is especially true here in Nashua, where our vacancy rate is very low and our rents are very high. So put those two things together, and when there is a vacancy, somebody's able to charge really high for it, and then folks that can't afford it often end up without a place to live. So sadly, there's lots of factors coming together for homelessness, and there are folks that can speak about this way more than I can. Other organizations where this is their sole focus or one of their primary focuses. But certainly we do know that there is a correlation with mental illness and substance use disorder and homelessness. And some of that's because of stigma, where people aren't given the opportunity to stay in homes, or they might make too much noise, or be too weird. And so there is a piece of that. There's also a piece of that often folks, when they have a relapse, whether it's a relapse of mental health symptoms or a relapse of substance use, that without the right supports in place, they might not pay rent on time or might not behave appropriately. And so keeping folks housed can be a challenge. And so kind of in the second part of that question, so what are we doing about it? So we've had a small program for a number of years that provided like subsidies or help to some of our clients with severe and persistent mental illness, with security deposits, or maybe paying back an old electricity bill so they could start electricity in a new home again. We've had that program in place for a number of years. In addition, our traditional services include things like we were talking about, where we go to people's homes and help them with things like paying bills, opening mail, taking their meds on time. But we also now have had for the past year, again, the state changed its approach with a program that they run called the Bridge Program. And it's meant to help folks who are struggling with a place to live and are waiting for HUD housing. So they're maybe on the list for Section 8, or they're on the list for some other housing. And in the middle, they're stuck. What do they do while they wait? And so that's where the name comes from, for the bridge housing. But it has specifically got some funds for staff, so that staff can contact landlords. Staff are in the home. Sometimes the staff even might have a second set of keys or have access to a second set of keys so that they can help landlords manage if any of those things do come up that would often have resulted in somebody being homeless. So we're really excited about having that opportunity. And again, we get to partner with others around that as well. We have a homeless outreach worker. Her name is Susan Mead. She's worked for this organization for over 25 years. I think it's close to 30. And she's got some great partnerships with the soup kitchen and other shelters in the area, and how if somebody shows up there with a mental illness and part of their mental illness is what's causing them to be or to stay unhoused, that her job is to help bring some of those folks into treatment. So hopefully if we treat them, that they're better able to remain in housing. And I see we have another really great question.
We do, yes. So many 911 calls to police involve people who are in mental health crisis and not posing an immediate threat to themselves or others. Do you think mental health professionals should respond to those calls instead of or with police?
The easy answer to that is a big resounding yes. The hard answer to that is, but how? And how to do it safely. So there is a program that the state is providing training to a lot of our first responders right now related to crisis intervention. So it's a crisis intervention training and helping them spot when there is mental health involved that may or may not have needed their assistance. And the idea is to bring mental health clinicians, specifically community mental health centers, and police officers side by side. So we have a small program right now where we're partnering with the Nashua police around if there is a child involved in an opioid event. So the child witnesses a parent or another family member who's overdosing or who's using. And so if the police see that, they refer to us. We respond with the police if necessary, or sometimes the police leave and we respond alone. So that's kind of on a one continuum of it. With mobile crisis coming, it is going to be vital that we work with the police department. And our ultimate goal is that people will call us when the police don't need to be involved. And that if we get to the situation, we then are saying, or we can help determine, does the police need to come or not need to come? It's kind of like if I were to imagine what it ideally would look like, right, is there's, and this is coming, there's 911 if you need police help, there's 988 coming to a telephone near you if you need behavioral health. But the two of those are not so siloed, right? And so that if you call this number, but you really needed this number, they talk to each other. So I think that's the part that we often struggle with. So in theory, it sounds good. We've got two doors, but those two places need to talk, and we'll get there. We're really partnering to do that. So, but it's a great question because I agree. I mean, that's part of why we're so involved in mental health court and the drug court programs, because we believe a lot of people need treatment, not incarceration, that sometimes people got to that door because the police were involved instead of mental health clinicians. And so things escalated, not for anybody's fault, but just because of the way the situation rolled out. So yeah, we're hopeful that things are going to get better in that realm. We're already seeing a lot of progress with that program and that training. So
it was amazing. Last week, our Leadership Greater Nashua class, makeup class from the spring, had Public Safety Day, and we ended the day with a presentation on drug court. And there were 5 different partners as part of that presentation. And honestly, it was one of the best I've ever been a part of. We did it on Zoom, but to hear the collaboration and just how thoughtful the whole process is. They each talked about their role, and then at the end they brought us through sort of a sample like staff meeting, right, if they had a new case, and it was imaginary, of course, but it was just fascinating to hear. It was just really great. So for those of you who don't know much about drug court in Greater Nashua, I would encourage you to look into it. So another question that came in ahead of time. So with limited mental health resources, how can our community help those in need?
So many ways. I mean, I think some of that goes back to what I was saying before about kind of just the general, how do we talk about mental health, being open to the conversation, being there to support people that don't need that highest level of care. And if we can, I don't want to say keep out because that's not the right word, but if people were getting helped at the community, then the resources at the higher level could go to those that really need that higher level. So what that involves is people not being afraid, right? Not being afraid to ask, not thinking, oh, I have to have a person here to have this conversation, because that's not always true, right? We're all human beings first, kind of where we started. So we've all experienced distress. We know how to talk to people. How would you want to be talked to? So that's a big one. The other thing that comes up for me is just encouraging people to be involved in this field. One of the things that people say that bothers me is, oh, what a thankless job. It's not a thankless job. I mean, I'm in my office, right? I'm on a Zoom. I got things all over my office from clients and staff and students expressing gratitude and thanks for changing their lives, actually, right? I mean, the EMDR treatment I was talking about in the beginning, I mean, I'm so thankful for having found that. So I also think, well, what's our stigma? How do we talk about the mental health field? If somebody approached you and said they were thinking about becoming a therapist, would you call it a thankless job? Or would you say, wow, there's so much need for that, and you're so great with people, what a great match. So I think we need help all the way back there too. That was a little bit of a soapbox answer. I apologize.
No, but I mean, it's true, right? It's back when I was at Stay Work Play, right? We used to talk about how it started with the parents. Like if a parent's definition of success for their children was get as far away from New Hampshire as possible, well, we're in trouble, right? Like even if
Exactly.
if they're sort of putting those kinds of expectations and opinions out there, it really does go that far back. So I think that's absolutely a valid point. So with only a few minutes left, is there anything either we haven't talked about or anything, if you could sort of leave us with something about the organization, about the field, about this world, what would that be?
That's a big question.
No pressure.
I think, for me, it really is just about mental health is part of a whole person, right? And it's not this thing to be scared of. It's not so different, right? I mean, if somebody has diabetes and their blood sugar spikes, we don't go, oh, I can't believe your blood sugar spiked. You're so not strong, blah, 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 blah. You need to get back into treatment. We give them insulin, we help them with what they need to get back on track, we coach them. But if somebody with a substance use disorder relapses, out comes the finger. We kick them out of treatment, for goodness sakes, in the old days. Or somebody, psychosis breaks through their medication, or they stop taking medication. It's no different than somebody that stops taking insulin. And so I really do just want to leave people with kind of that thought that it's mental health and physical health are just part of health. That we really should be about what does it take to make our community, make our families, our organizations healthy. And that includes both physical health and mental health.
Excellent. That was a great way to wrap up. Thank you so much.
Oh, you're welcome so much.
We appreciate you being here today. Thanks to all who joined us. We do record these. We'll put it up on our YouTube channel for reference later. And we appreciate you. Happy anniversary, 100 years. It's amazing. I'm sure there's more to come.
Well, thank you so much, Kate. Thank you for having me here.
Thank you. Have a great rest of your day.
All right, you too. Thanks.
Bye.